Sean is the acting lead for HIV care and treatment at the Office of the Global AIDS Coordinator and the former senior TB technical advisor. He's on long-term detail from the Division of Global HIV and Tuberculosis at the US Center of Disease Control and Prevention, where he previously worked with the Global TB branch. And he's going to talk to us about the tools that we need to scale up TB preventative treatment. So over to you. Thanks.
Okay, so I'm going to speak mostly about scaling up TB preventative treatment in PEPFAR, largely because that's what I know, not because this is a template that everybody would need to follow. So we're going to start with the TB indicators. We have a suite of 4 indicators that we use to follow programmatic progress and gaps and deficits. The 2 here at the top, TB stat and TB ART, are not really relevant for this talk, but those are very quickly. Stat is the number of TB cases that has an HIV status documented. TB ART is the number of those that are HIV positive that were started on ART. So I won't say anything more about those for the rest of the talk. The bottom 2, however, are of interest. TXTB is our new indicator. It's, the denominator particularly is of interest to us. It's the number of ART patients that were screened for TB at least once during the course, during the reporting period. And then TB-PREV is an indicator geared at getting completion. So the denominator is the number of ART patients who were projected to complete TBT, and the numerator is the number that did. And I want to make a note that these are mandatory. Reporting on these are mandatory, and that is a deliberate attempt to drive programming in PEPFAR, because what gets measured gets done. What doesn't get measured often doesn't get done. And so those last 2 indicators allow us to look at, this is our TB cascade, TB prevention diagnosis cascade. Starting here in the middle at that green bar, that is the number of patients that were screened. And we compare that to the number of patients in treatment, our TX-CUR. And where there's a gap there by country or by demographic, that's an interesting thing to follow on. Going to the right of that, we have the number that screened positive, and then after that, the ones that had a specimen sent, then the ones that had a positive result returned, and the ones that were started on TB therapy. Following that cascade gives us the TB diagnostic and treatment gaps and fall-offs. Back to the green bar in the middle and going to the left, the first orange bar is screen negative, and that immediately will give you the number that should theoretically be put onto TB therapy. Big fall-off here. This is our Q2 data for all countries kind of rolled up. And the second orange bar in is the number that are expected to complete TB preventative therapy, those that were started in the previous reporting period. And the yellow bar at the end is those that did. We also disaggregate those data so we can look at it by different populations. We have age and sex disaggregations, and we've seen some really stark differences there. And importantly, we have start of ART, so we can look at those that are newly enrolled into care versus those that were previously enrolled into care, and I'll get into that in a second. And then we can disaggregate by type of TB preventative therapy, whether we're talking 3HP, 1HP, or just 6H. And then on the other side, TXTB, we have those same disags and also result of screening. So we can really dial down into who screened positive, who were they, and what was done, what was or wasn't done for them. And so this is the cascade looking just among those that are newly enrolled in PEPFAR. And this is important in countries like Kenya and Malawi, who have already covered a good number of their people in treatment. So if you look just at those that are newly enrolled, that's how we'll follow programmatic progress in those countries. And you can see, again, this is all of PEPFAR all rolled up for this fiscal year, this current one. This is the year before we have a major effort to scale out TPT, so expectations are low, but I'm not even sure these numbers meet them. The number that's screened negative is just under 1 million, but only 27% were initiated on TPT, and our completion rate is 51%. So that's already bringing up a bunch of red flags for us to work on. Okay, so in addition to the indicators and our ways of monitoring, we also conduct a fairly tight surveillance of TPT program activities and needs. And we do this with an army of subject matter experts at our implementing agencies who are in regular contact with their country points of contacts. And we have a running list of issues by country that we hold at the agencies and at OGAC, our main office. And then our implementing agencies conduct periodic surveys of current landscape and needs and issues. And recently we had, I guess about a year ago, we had a 48-question survey that went out to the PEPFAR country teams inquiring about all manner of TPT issues. And from that, this will be no surprise to anybody in this room, we had a long list of obstacles that we've developed that we need to address. Among those are healthcare worker beliefs and concerns, particularly around adverse events, lack of guidance on provision of TPT in differentiated service delivery models, a very hot topic that we're hoping to have a lot of conversation here this week. Countries have a lack of tools for recording and reporting, limited experience with adverse event monitoring, lack of clinical algorithms, and limited experience with procurement and supply management. And so we developed from that again, the colleagues at the agencies, the implementing agencies, USAID and CDC, developed this operational toolkit that is designed to address those particular obstacles. It's a suite of somewhere around 23, I think now 24 specific tools. There are very many of them because that allows them to be very specific and focused. And they're categorized into these here sort of 5 arbitrary categorizations: policy and planning, pre-implementation, preparation for implementation, early implementation, and routine implementation. And we'll go over some examples of these in the next few slides. I want to make a point that these are not meant to be mandatory. These are merely for reference for country teams or implementing partners that are having particular issues. The toolkit and the individual tools are very much living documents. We're constantly updating them. The kit itself, this actually is a brand new visualization because we expanded, and the individual tools. And they're fairly standardized. They each have a cover page with a description, the intended users, and the goals and instructions. So maybe we'll look at the two. I'm just kind of randomly picking a couple here. Our Mythbusters has been fairly popular, and the frequently asked questions for patients. So the myths tool is a slide deck. It's kind of a comprehensive review of common myths and the evidence behind them. That one gets updated every few months as the new studies are coming in. The frequently asked questions for patients is a one-page document. It's adaptable. It's for translation. It's meant to be an education for patients on why they're being treated, how to take and adhere to their medicines, and side effects to watch out for. Back to the toolkit and adverse events. We'll look at the TPT register, which is a deficit that we've identified, and we'll talk a little bit about that in a minute, and then adverse events. So the register, we've heard from a number of countries that they anticipate real difficulties reporting, and an obvious solution to that is yet another register. But this is, in countries that have developed this, has turned out to be a very useful tool for being able to rapidly conduct their own operations research, pivot where they need, identify their own gaps, and report on up. So we are encouraging a separate TPT register for PLHIV in clinics, and this is just an example of how that might look. This is more of a clinical chart that would go back in the patient's chart. This is a form for TPT follow-up. And then our adverse event algorithm. So this is a critical one that has captured, I guess, the fears and imaginations of a lot of people. Adverse events are what get a lot of press, and it's often proffered as a reason why TPT has not gotten off the ground. So we want to make sure we're addressing that adequately. And this one starts up at the top with assessment for eligibility, or assessing for contraindications to TPT. We want clinicians to use TPT widely, but wisely. There are people that should not get it. And so this one kind of takes the clinicians through how you might be judicious in when you're prescribing TPT. And down at the bottom, we have a couple of slides in this deck that will go through how you manage adverse events should they occur. Okay, then we have a couple of clinical algorithms. I think in the interest of time, I'm going to move through and just show you the pediatric algorithm. Probably a lot of people in the room have seen this. This is fairly standard, but this is something meant to be blown up and put on the wall or kept in a clinical guide for clinicians while they're dealing with kids. And this goes all the way through for TB screening, diagnosis, treatment, and TB prevention. And then we had a costing tool, and I mean, this is terrible, you can't see this, but this is there to remind me to tell you that we are very eager to update this when we get some new prices or those negotiations that were alluded to earlier. We are very eager to get those prices fixed. We want to promote those shorter regimens as our preferred regimens. And for us, that hinges on what how those price negotiations end up. So we're very fixated on updating this tool as broadly as we can. Okay, this is my last slide because, and just to sum up, here's how then we're operationalizing TPT and PEPFAR. I think most folks know that we centrally calculated targets for TPT for each country, and we identified minimum budget allocations. That did not make us particularly popular with our teams because we were, in a sense, imposing targets on them. But we are anticipating a very dramatic liftoff of TB preventative therapy starting in October of this year, our next COP cycle. We have real-time communication with country teams and the implementing partners, and we technical assistance as needed to ensure the country readiness. And there's a mad scramble this summer to get countries positioned well for October. Our procurement and supply management has been fully capacitated. These are our partners at USAID, and they are participating in the coordination of global supply of all the different regimens. We've established a TB-HIV community of practice, interagency. Right now, it's just within PEPFAR, but we're coordinating with other agencies and groups like WHO, CQUIN, Partners in Health, and Impact4TB to develop kind of a loose federation of communities of practice so that we can make sure that we're synergizing and amplifying the work that we're doing out there. We don't want to say that we don't want to be. We want to disagree with other TA that's going on, and we want to make sure that we're fully complementary and fully synergized. Okay, my thank you slide, somehow I missed that, but I did want to thank very quickly some of my colleagues at OGAC, Katie Godfrey and Tia Balsamarai. She's our new TB technical advisor, and then the folks at the implementing agencies, USAID and CDC, who've actually put this entire plan and toolkit together, and then the folks and the implementing partners throughout all our countries that are right now working incredibly long hours to get things ready. Thank you.